Hello, everyone. Thank you for having me. My name is Tony Delonzo. I am the Vice President of Clinical Strategy and Innovation with Bayada Home Healthcare, and also a physical therapist by profession. Excited to join you today. Goal of my conversation, at least for the early portion, is to give you a little bit of background around home healthcare and specifically how we approached telehealth in the home health setting. I'm going to jump right in. And for those that are not familiar with Bayada, we are the nation's largest nonprofit provider of home health service. If you count the for-profit agencies, we run about number 5 or number 6, but largest among the nonprofits. We operate in 22 states, headquartered in Morristown, New Jersey. I live in Pennsylvania, just north of the Philadelphia area, where I'm recording from my basement right now. And we have about 26,000 office and clinical staff. We have a variety of different service lines, including pediatrics, hospice, personal care service, but I primarily represent our home health service lines, or typical Medicare certified home health, which has a census right now of just over 20,000 patients nationally. Interestingly, that is our record census, as this time last year during the pandemic, we dipped down to about 16,000, as we saw a pretty quick decline and then a pretty steady recovery, especially over the last few months, as we're seeing more and more patients being diverted from subacute, primarily skilled nursing, inpatient rehab, to the home setting following hospital stays. So home in some cases being the location of preference in post-acute care. Going to the next slide, I wanted to dive a little bit deeper into home health, as I know not everyone may be familiar, but primarily I'm referring to short-term Medicare certified physician directed care. Medicare funds about 60 to 70% of our patient population, where the other 30%-ish funded by commercial insurance, Medicaid, other third-party payers. So Medicare definitely makes up the bulk of the patients that we see in home health. Medicare pays on a 30-day prospective payment system. I think this is important as we talk a little bit deeper about telehealth and funding for telehealth. But traditionally, Medicare will pay, so we'll go into the home, we'll do an assessment of the patient and put together a clinical profile. And Medicare will say, based on this clinical profile, we believe it's going to cost X dollars for the next 30 days. We get a lump sum payment. It's really up to the individual home health agency to then determine how do we want to use those funds. So we can provide any combination of nursing service, physical therapy, occupational, speech, social work, or home health aid service. But Medicare doesn't dictate a specific number of in-home visits. What we would call a treatment is a visit. We're not held to a certain number. It's really up to us to use that funding from Medicare and to mix and match service as appropriate for the patient's need and the individualized plan of care for our patients. So I wanted to get a little bit deeper into the telehealth specific terminology in home health. So I know you're going to hear a lot of different telehealth terms today. They might be used sometimes interchangeably, but when we look at telehealth, we look at 2 very specific categories, which is virtual visits, which is a replacement for an in-home visit with a virtual visit. And we look at telemonitoring, which is a remote patient monitoring, kind of continuous monitoring of vitals. So just to get a little bit deeper into the 2 categories, delivery method for virtual visits, these are remote visits, synchronous, conducted via video or phone, whereas telemonitoring usually has a third-party system, peripherals like blood pressure, weight, pulse oximetry, pulse, a variety of different vitals that will feed into a central monitoring system and then create alerts if someone is out of a normal range of parameters. We kind of set the range, and if someone's out of the range, it will create an alert. The goal is a little bit different between the 2. So for virtual visits, the goal is to facilitate some level of patient interaction, either in addition to the existing in-home visits that we would already be conducting, or in lieu of an in-home visit. I'll get into some more specifics into those different drivers. But in some cases, if an in-home visit is not appropriate, but that patient still needs care, then can we provide it virtually just to keep that consistent interaction? Telemonitoring, as I mentioned, is more of a daily monitoring. So it gives us a consistent feedback loop around vital signs and early warning for any changes in status. The virtual visits could be delivered by anyone on our clinical staff or nursing therapy, as well as social workers, who actually did the majority of our virtual visits, was our social work team. Telemonitoring for us, at least at Bayada, is run by a centralized nursing team. We have a central group who monitors the alerts coming in from our telemonitoring system across a large number of different Bayada locations. We just found it easier to centralize and create that consistent process across our teams. Scalability. This was a really important factor for us in thinking through how easily is it to quickly expand this service to multiple patients, especially as we started to hit the pandemic and things really started to change in the home health setting. Virtual visits have a fairly high scalability. All of our clinical staff have tablets where they do their documentation. They're equipped with Zoom. They have some familiarity with Zoom or virtual interaction, as we've historically done staff meetings. We do daily morning, what we call huddles, where we talk about any new patient internally, and that's usually done via Zoom. So our teams were used to video interaction and kind of facilitating video touch points. Telemonitoring, on the other hand, I would say is a low scalability, only because we're restricted in the number of telemonitoring devices that we have per location. As we tried to acquire more early in the pandemic, was actually difficult as everyone was sort of trying to ramp up their remote patient monitoring. But in a typical Bayada office where we might have a census of 300 patients, we may have 10 telemonitoring devices. And so it's very difficult to hit a large number of patients with a constrained number of devices, not as easy to scale up. And the last factor here is reimbursement. On the managed care side, we did have select payers who would reimburse for virtual visits, for video touch points, and a very few that would actually reimburse a small amount for phone touch points. But with most of our patients under the Medicare umbrella, Medicare did not directly reimburse for virtual visits or for the cost. Most of our telemonitoring, remote monitoring systems come with a monthly cost, a monthly subscription fee, which was not covered by Medicare. So the way Medicare looked at it is that, remember I mentioned they pay a 30-day incremental lump sum payment. So while there was no additional reimbursement for virtual visits or for telemonitoring, the Medicare argument was use the dollars we're paying you to cover the telehealth service. Sounds good, but if we are going to provide in-home services as well, every time we send a nurse, every time we send a therapist out to the home, that requires a certain number of dollars of cost. And so what we would have to do is separate some of that lump sum payment to reimburse ourselves, basically to use that to fund the virtual visits or telemonitoring, which would then sort of become a balancing act in a sort of fixed 30-day reimbursement. And so no additional funding, unfortunately. It's really up to us to determine how much of this virtual service can we fund and what's appropriate. I'm going to spend a little more time. We'll set telemonitoring aside for the moment and get a little bit deeper into virtual visits, which we did not typically use prior to the public health emergency. We certainly did phone interaction with our patients, but not really intentional video interaction meant to complete a full clinical assessment or an intervention that we would have otherwise done in person. But the pandemic necessitated a really rapid development of a billing structure for the payers that would reimburse, but also how do we document this? How do we capture the patient consent? How do we train our teams into conducting a virtual assessment or virtual interventions, which is something that many of our staff, nurses or therapists, really haven't done historically. The deployment decision was made at the individual level, so picking out which patients are appropriate. How often do we want to use it? How do we intermix these virtual visits with in-home visits? We really relied on our local teams to make that decision, to stay nimble, to really deploy quickly. So we tried to keep it at least structured from the baseline expectations and then allow for flexibility among the individual clinicians and managers for the local level. And then we, saying that, we did create a feedback loop. So we had a variety of different team meetings. We did touch points with different managers to gain feedback, to make adjustments very quickly to the process. Getting a little bit deeper into it, the patient selection, we did provide guidelines around who's appropriate for virtual visits and who's not. So we said, who do we want to consider for virtual visits? if it's medically contraindicated to enter the home, or if they live in an assisted living or senior living community where we couldn't get in, because some of them closed to visitors, even including nursing and therapy staff, perfect candidate for virtual interaction. At least very early in the pandemic, if we had limited access to PPE, or if it was unsafe to enter the home for one reason or another, could we then augment or add virtual touch points with the patient? And the number one reason, this third bullet here, is probably the number one reason we used it, was patients were refusing care unless we provided it virtually. So they either didn't want multiple clinicians coming into the home, especially with this fear of COVID early during the pandemic. So we said, let's offer the opportunity to interact virtually as an option, because these are people who are high acuity patients, they're homebound, they need some level of care, they need some level of clinical intervention, and we don't just want to abandon them because they don't want someone coming into the home. Let's see if they'd be open to virtual interaction. Not appropriate for something that required true hands-on treatment like wound care, IV, something where we actually would not be able to provide that through a video or phone, unless we were coaching a caregiver. In some cases you could, but for the most part, if it's hands-on, you had to be in there. We did not allow our teams to do the initial evaluation virtually. We just felt that you had to see the home, you had to see the home layout, you had to assess the safety of the patient. You didn't necessarily want someone standing up and giving a tour of the home who was unsafe. It could lead to some concerns down the line. And not appropriate for clinician or provider preference. That's the other big one. Is we said you can't just sub in a virtual visit because you don't want to go into the home. If the patient is open to it and we can get in there and we have the correct PPE, we're safe with infection control, if we're safe going in, then we have to go in. We have to get in there. It's our duty to our patients to make sure we're providing the best service we can in person if they're open to it. Interestingly, only half of our patient population had access to a smartphone, tablet, computer, or we also asked if they had caregivers, if they had family members, someone else in the home who could help facilitate. But that right off the bat sort of limited virtual interaction with a chunk of our patients as well. So what actually happened? In 2020, we did 4,050 virtual visits. Only 84 of them were conducted by therapists, the majority physical therapy. So you say, well, that's a pretty small number considering the total volume, which the majority actually completed by social work. So we found social work was very conducive to virtual interaction. We could conserve PPE, and it didn't necessarily take away from the spirit of what we were trying to do with connecting to community resources and other things. But for our therapists, we really prioritized, as I said, getting out to the home if we could get out to the home. It's only primarily if the patient was refusing and they still needed the care, could we then conduct that treatment virtually. 4,000 sounds like a lot, but over the course of the year, we did just over 700,000 total visits. So really only a fractional number of visits conducted virtually, the majority still done in the home. And the most important outcome that we track is our hospitalization rate in the home health setting. So for us, the 30-day hospitalization rate, meaning from the time someone comes on service to 30 days out, do they end up back in the hospital? Nationally, we average about 15.3%. For patients who received a virtual visit at some point during the course of care, it was slightly higher at 17.7%. We're still digging into those statistics. I will say that the ones receiving virtual visits had a slightly higher acuity. So when we adjust what we would call for a case mix weight, which is sort of like a roll-up of the clinical factors, when we adjust for acuity, there is not really a statistically significant difference in hospitalization between our total population and those receiving virtual visits. So I can't conclusively say subbing in-home visits for virtual visits led to a worse outcome or led to a better outcome. It's something we continue to dig into, and we're looking more closely at our functional outcomes as well. But the big one being hospitalization in home health. So I'm looking forward to the panel. We'll have a little bit more conversation about this, but a couple of thoughts just to leave you with is, even with the pandemic, the transition to virtual care and home health has been slow. Really thinking about our patient population, the high acuity, homebound population, access to technology is a limiting factor. it will kind of jump around here, but in the absence of direct reimbursement, unfortunately, innovation sometimes is driven by payment, and in the home health setting, without any additional payment or without really clear intentionality around payment to be used for telehealth, we're not seeing an extremely quick adoption yet. And also, staff require really clear expectations. If you want someone to adopt a new treatment style, we shouldn't make the expectation that you can hand a therapist a tablet and say, here you go, do your visit virtually, because it's definitely its own skill set. And the better picture we can paint of examples of interventions, video examples of someone doing a virtual visit, checklists and bullet points around here are the ways to conduct a virtual visit. The more details we can give, the more likely someone is to adopt it. So we did see hesitation among the field staff, our clinical staff as well. So those were the facts, and I'm looking forward to getting a little bit deeper into the feelings in our panel conversation. So thanks for your time.